to help inform that discussion about switching, we need to talk about how do we monitor these patients to know when we're switching. So Jorge, can you lay out what are the guidelines for and how do you monitor patients who have started on an able TKI? What are you looking for?
Yeah, I think that it is very important, and the major agencies that have given us information on these, ELN and NCCN and all of these, they have very similar recommendations. And I think it is very clear to all of us that the close monitoring is critical to optimize the benefit. There's no question that some patients are going to do well even if you're not looking. But you are going to miss the patients who are not, or you're going to miss them early when you could have changed the impacted the outcome. So basically, and what I do is pretty close to what these guidelines recommend. I do every 3 months for the first year. Once the patient gets a deep, stable, at least a major molecular response, and that's stable, I go to every 6 months, and I stay with every 6 months. Some have recommended that later on you should continue with every 3 months. So for example, the ELN says every 3 to 6 months. I think once the patient has a very stable response, every 6 months is fine. I may do every 3 months if there is, if I reduce the doses, or there is a question mark about a value. We talked earlier that a small variation. Well, I may want to check it a little bit sooner if it's going in the wrong direction, etc. We can do that with PCR alone. I still think there is value of doing after start of treatment an occasional cytogenetic analysis early on. I think 6, 12 months could be valuable because there's a small subset of patients who develop chromosomal abnormalities in the Philadelphia negative metaphases. And it's about 10 to 15% of patients. And those patients may have both a different outcome from the CML and the potential of developing rare, but occasionally MDSs and AMLs. That's not blast phase, just a different disease. But those tend to occur early. So after the initial year or two, maybe doing 1 or 2 bone marrows and making sure that those haven't appeared. And if the patient has a good response, then just the PCR is important. But again, in the first year, some important time points where we know where you want to be for having an optimal response are 3 months, 6 months, and 12 months are very important, and then 18 months. So those are time points that we should not miss on any patient. Everybody should be monitored at those time points, and then, of course, continue every 6 months after that.
Mike?
I'll use 2 terms. Well, play in the zone, but we don't want to be developing PCRitis. But I think once a patient gets into response, I agree that molecular response is the workhorse. I think I actually use molecular response late as a reinforcement to continue to engage the patient. You're continuing to do well. You're continuing to show stable deep remission, or it's deepening. You don't want to overdo it. That's where the PCRitis comes from. If you can look at it too much, then you're looking at lab variability and disease variability as it's probably extinguishing over time. It's true. The good news is that most patients may do well without more intensive monitoring. So I got to strike a balance, I think, to see what's going to serve the patient the best. And probably to remind everybody that in the U.S. and abroad, but we actually don't monitor as much as we should as a community. We've seen data on that even just the bare minimums, as you just mentioned, Jorge, the key milestones, the early molecular response, looking at cytogenetics within the first year, or molecular testing within the first year sometimes doesn't happen. But I think the molecular data collected over time helps us have confidence about TFR, which is really a new agenda item. We don't have to have reams of data, but we do need sufficient data to really judge a patient to be eligible. So we have to marry those agendas.
Adding to that, I would just want to, one expression that I use when I talk about these things is that to me the molecular responses are a measure of, they're not a measure of failure, they're a measure of success. Not a patient that hasn't achieved an MR 4.5 but has an MR 4, they're doing pretty good. Yeah. If they have an MMR, they're doing great. They're going to live a normal life expectancy. Now, they're a measure of success because if you want TFR and, okay, you want to get deeper. But that patient is not failing therapy. They're doing well. So are you going to transplant that patient? Of course not. Are you going to change therapy? Well, depend. If you want to get deeper, let's see what, maybe you just need to optimize their dose. whatever. But speaking about the PCRitis, you don't want to overdo these things. Not everybody has to be negative in the PCR.
So I'd like to add in a few things. In terms of monitoring, I think it's important to understand why we're monitoring. If we tell people that you have to come in for monitoring and don't tell them why, then you're going to lose it. And again, it has to do with education, but of the patient, education of our referring physicians, people out there treating patients. The reason why we check at 3 months is that there's very good data that started from the Hammersmith with 280 patients treated with imatinib, showing that the BCR ABL to ABL ratio at 3 months was informative regarding progression-free and overall survival. Roughly, if it was above 10%, those patients had a PFS and OS of about 57%, and was 93% if it was under 10%. So that has been adopted into ELN and into NCCN guidelines. At 1 year, this is where it gets a little confusing because people like us confuse people, and recommendations confuse people. How deep a response do you need? My opinion is if a patient is tolerating the drug, being compliant with the drug, and they achieve a complete cytogenetic remission at 1 year or a BCR ABL ratio of 1% or lower, to me that's sufficient. And I would then continue to monitor, making sure that's stable and getting better over time. Because those patients will do as well long-term as patients who have a major molecular response. Now, if you achieve a major molecular response by 12 or 18 months, you're less likely to lose that complete cytogenetic remission, but in terms of survival or progression, there's really no difference between a CCYR at 1 year and a major molecular response. So in terms of my goals for patients until now, it's been achieve, compliant with drug, tolerating it, achieve a complete cytogenetic remission, and hopefully you'll see that BCR ABL ratio go down over time. Now I think we have a new endpoint, which is different, and that's the MR 4.5 that we'll talk about later in terms of treatment-free remission. The only other thing I would add to the discussion is I fully agree with all of your comments about the risk of Philadelphia chromosome negative cytogenetic changes. They do occur. I don't personally repeat a marrow to look for those because, as you know, we don't really know what to do with that data. We'll monitor those patients by their blood counts. We're not going to send them to transplant. So it'll really be a change in their blood counts that would trigger me doing it. So I understand what it'll show, but in my clinical practice, I don't do it.